Well, thanks so much, Christy, for that lovely introduction. And thanks so much for joining us today. As Christy said, my name is Shivani Patel. I'm an ID clinical specialist here in Houston, and I'm really excited to share our DoseMe journey with you today. Thinking back to our DoseMe experience, we've had a long and rewarding path to kind of where we are today, and I hope that sharing our experience makes your journey just a little bit easier. Before I get started, though, I also want to acknowledge the work and efforts of the Memorial Hermann Infectious Disease Specialist team that really kind of led and supported our implementation. And everything that we're going to kind of discuss today was really as a result of our entire group's work and effort. And so I just want to thank them in advance for everything that they do. So Memorial Hermann is a network of 13 acute care hospitals in the greater Houston area. And although we are a system, each one of our hospitals operationalizes and implements things just a little bit differently because of differences in staffing models and in campus needs. And so I think this is really important because I think that our experience really shows how we did this as a broad system level, but also potentially how smaller individual hospitals can kind of use and adapt some of the things that we did to implement at their facility as well. We really needed a process that created standardization across the system, but also allowed for flexibility. Our system employs about 200 full-time pharmacists. We have another 200 part-time PRN pharmacists that support us. And then within our clinical pharmacy group, we have 13 dedicated ID physicians, with 7 of us being full-time and then 6 of us being split between other roles. Prior going live with DoseMe, our hospitals were a mix of pharmacy dosing and pharmacy and physician dosing. And so workflow was a really major factor for us because we needed to get everybody up to 100% dosing. And as we thought about how to implement Bayesian dosing and an integrated platform, this was one of the things at the forefront for us. Also, in terms of volumes, we see about 100,000 vancomycin days across the system, and every patient for us is evaluated every day. And so this is a really big work burden on pharmacy, and that was a really big consideration for us if you're similar hospital of size or shape. So why we chose an integrated Bayesian dosing algorithm. So we opted for a fully integrated version of DoseMe, and I want to kind of review some of our big rationale for why. Number one, scalability. We wanted to maximize the number of patients that were being dosed via Bayesian dosing because number one, we think it's the right thing to do. We think it's the right thing for patient care, and we were investing in the software and the resources to be able to train up our staff. And so we did not want to live in a model of two different worlds of vancomycin dosing. The second thing is we wanted to reduce levels. We wanted to be able to offset some of the costs that we were incurring by reducing costs associated with levels. And then the scalability really allowed us to get early levels and then reduce the number of overall levels. In terms of guideline compliance, we wanted to transition to AUC dosing because it's the best practice standard. And some of the first order calculators that we looked at online, as well as some of the online platforms, required multiple levels, complex calculations, and we really wanted something that was a little bit more streamlined and easy for our staff to be able to do. In addition to that, we really looked at quality. And I think for me, this is like the beginning and the end of any sort of initiative or innovative practice that I think that you're going to implement at your hospital. We have to keep the patient at the forefront of everything. And Bayesian dosing really allowed us to lower vancomycin doses and reduce AKI rates to improve safety. And this was really our big selling point for the medical staff and C-suite. So all of these factors combined help us kind of consolidate therapy and standardize care, make implementation possible for us. So the benefits of integrating into our EHR were pretty simple for us. Number one, we had excellence in efficiency and workflow. The integrated solution allowed for easy access within the current EMR, and I'm going to show you some screenshots of this, and allowed for our staffing models to accommodate the new workflow. We decided that it was much more cost effective for us to invest in the integrated software than it was to hire additional pharmacy staff and get them trained up to be able to accommodate moving to 100% pharmacy dosing for us. The direct data feed saves so much time, and I can't say this enough. Our pharmacists do not have to input labs, doses, levels, and it was really a game changer for us. And it also, I think, provides an additional safety layer in terms of the fact that we limit data entry errors because nobody's actually having to manually input data. Finally, I think a big selling point for our staff was the fully integrated notes that the integrated version allows us to do. Prior to DoseMe, our pharmacists were hand building notes. And so they were manually inputting levels, labs, and dosing regimens. And all of that we were able to eliminate with the implementation of DoseMe, which really allowed for additional volume and capacity for our pharmacists to continue to dose vancomycin. Oh, I think I went a little too fast. Let's see. There we go. So this is what our integrated model or integrated workflow looks like. So the first thing that we're going to do is we're going to select the course. We're easily able to see the courses that are available to us and then pick the models that we want to choose. At our campus or at our system, we opted for the availability of 4 models. We have a 1 compartment, a 2 compartment, an obese, and a hemodialysis model that our pharmacists have to choose from. The next thing that we wanted to do was view our dosing recommendations. So as soon as you choose your model, it opens up your dosing recommendations that are very face front for you to be able to see, and the pharmacist can decide whether they agree with the dosing recommendation or whether there's something about the patient that requires customized dosing, and they can do this very quickly, which really improves efficiency for us. The last piece of this is the integrated note. And as you can see here, the DoseMe note really provides a lot of the data that our pharmacists were manually entering prior to implementation. So target levels, outcomes, peaks and troughs, and all of this is rolled up for us. So our journey has been a long one. We started with engaging stakeholders, evaluating dosing, building the protocol. And so I kind of want to talk you guys through some of these steps and kind of how we got from the beginning to end. So I think the first thing for us is the fact that we got engaged. We started at the top, hospital administration and the C-suite. We engaged system quality and safety, and then the pharmacy directors as well. And our selling point for all of these people were that we were able to streamline process, we were able to improve productivity. There's a value add now from the pharmacy and the fact that we're able to do things like reduce AKI rates, reduce vancomycin levels, and we were able to see like a return on investment with Bayesian dosing. The next group that we had to get buy-in for was the physician, nurses, and the staff pharmacist. I feel like the medical staff was pretty easy for us. Bayesian dosing is complex. Let us help you with improved dosing strategies, lowering your vancomycin dosing and reducing AKI in your patients and essentially helping you take care of them better when they require vancomycin therapy. Our goal was to get those last remnants of our medical staff who were still dosing vancomycin by themselves on board with Bayesian dosing and get us to 100% pharmacy. For nurses, our big selling point was reduction in timed levels. We decided to move to random levels that we get the morning after vancomycin is started. And because of this, we're able to do it with AM labs. And so it's not an extra trip to the room for the nurses anymore, and it's not an extra blood draw, which I think has improved patient satisfaction as well. And then finally, I think staff pharmacists we really needed to introduce the concept to them when we decided we were going to move to Bayesian dosing and really get them to buy in, get them not to revolt. Change is hard, and we really wanted to prepare them for how to do this. We wanted to make sure that they knew what was coming, and not only that this was coming, but how we were there to help and support them through a pretty significant change in their workflow. Finally, we had to gain support. Staff with IT, we needed to stay engaged with the implementation process, and then staff pharmacists again, education, support, follow up on their mental well-being and making sure that they were okay once we went live. You know, I had 6 to 9 months to get ready for the DoseMe conversion. I was, readily vetted and the planning stages, how we were going to do this, how we were building workflow. But our staff got some education, some hands-on live training, some patient cases, and then they had to be ready to go. And so they didn't have nearly the amount of adjustment time that I did. And I think that's something that we really had to be sensitive to as we kind of move forward. The next thing that we did was review the guidelines and the clinical data. So we looked to ASHP, IDSA, all of the big guidelines to provide rationale for dosing. However, we did not provide a how-to for this when we engaged our medical staff. Then we had to decide on exclusion criteria. Who were we going to include? Who were we not going to dose with vancomycin? And what we ended up deciding was that we were going to exclude patients with unstable renal function, and we define this as a serum creatinine of greater than 6, and that's the cutoff that we felt comfortable with, but I think it's very flexible in terms of what you want to do. Um, Central nervous system infections was another big point of conversation for us, and we actually decided to include these patients. And then finally, CRRT and peritoneal dialysis patients, we have a separate algorithm to dose these patients. But really, our end goal here, after we reviewed all of the guidelines and clinical data, is that we wanted to maximize the number of patients that we could dose with DoseMe and use Bayesian dosing with. The next thing that we had to do was create the protocol itself, and I think this was probably the most time-consuming thing for us. Um, we had so many iterations of this protocol, and I think it really comes down to the people that you're engaging to build the protocol. For us, it was the ID physicians and the ID pharmacists, and we needed to get buy-in and education from nursing lab and our IT support services. The next thing is how you're going to actually build your protocol. Are you going to be renal function based, disease state based, or DoseMe model based? And what I mean by this is that if your renal function based is the first thing that your pharmacist is going to assess is the patient's renal function, and that's how you decide how you're going to move through the pathway. Are you going to move through model selection based off of whether it's cellulitis or a CNS infection? Or are you going to start with a one compartment model always and then go to two compartment models if you need to for different variations? What we learned was that the protocol development and the work efforts really should be done in parallel with your IT development to be able to keep on the same time. What happened to us is that we underestimated how long the protocol was going to take to build for us. And so IT was ready to go before our protocol was built, and it delayed the clinical implementation. Next is creating the protocol. And so what we did was we essentially dosed everybody that we could with a goal AUC of 400 to 600, with our default target set at 450. And the reason that we chose 450 for the default is that when you choose 450, you're actually kind of targeting somewhere between 400 and 500, because the number is not going to be exact every single time. We For trough-based dosing, we kept a trough of 10 to 20 micrograms per milliliter, and that's for CRRT and peritoneal dialysis patients. And then for anybody who was stable, or a serum creatinine that was greater than 6, we just dosed them to a trough of less than 20, and we dose based on levels. So after considering all of this, this is the decision tree that we came up with. And so I think this was really key for our pharmacists to be able to maneuver and make decisions on DoseMe in terms of what level do I choose, what my AUC goal is, and then what are their directions in terms of monitoring. So the first thing that we look at for our patients is vasopressor therapy. If they're vasopressor therapy, if they're on vasopressors, they automatically are treated with a 2-compartment model. If they're stable renal function, then they go to a 1-compartment model. And then hemodialysis patients go to hemodialysis. And then as you can see, as you move down the tree, we're going to dose trough-based dosing or one-time dosing by levels for those patients who aren't incorporated. It was very confusing before we developed this for our pharmacists to be able to navigate. So this was something that was really important for us to think through and build on the front end. In terms of feedback and editing, I think it was really important to remember the staff pharmacists and their role in this. I think their questions and their engagement in how we use DoseMe was the key to our success. Us as clinicians were so deep into the process of building this, we just assumed things that were not clear to everybody else. And so I think their fresh eyes, their daily use of the software, and the questions that they were asking really led to great questions and significant change that improved the way that we're taking care of our patients. And so I'm really glad that we were able to engage them in this process. And it was really the little big things for us. So, for example, understanding our serum creatinine and weight cutoffs and how that impacted what was happening to the pharmacist. In the very beginning, we had these very strict serum creatinine cutoffs, and we did not realize how many patients we excluded from dosing Bayesian dosing because of that, and we ended up adjusting ourselves and widening our net. The same thing with the implementation of the random level. This was new for us, and we sold all the benefits, but we didn't realize it that nurses didn't necessarily 100% understand, and they were holding bank doses because of these AM levels, which we expected to be high. And also, physicians were discontinuing vancomycin therapy that was needed because they saw a high level, and they didn't know what to do with it. And so making sure that you've got that active surveillance for these patients. And then how you're going to keep track of all of your vancomycin patients. Are you going to use a work list? Do you have a spreadsheet? What does your handoff look like? How do you hand off levels? Um, I think all of those things were really important. So I think our big lesson learned was that each staff member who used DoseMe, it took them only about a day, one shift, to feel comfortable with the software. It was very easy to navigate and very easy to learn. But I think we realized that our staff needed 3 to 5 days of consecutive vancomycin dosing to really be able to navigate the protocol well and kind of establish some sort of clinical expertise in how we thought in the thinking part of the protocol. The last piece here is educating our staff. And so for our pharmacists, what we did was we did didactic education, which was a pre-recorded CE, so that they understood the rationale and the basis for AUC dosing, because as the questions don't come to the clinicians 100% of the time. And so we wanted our staff to be very well versed in why we're doing AUC dosing, what the benefits are, and to be able to answer basic questions from the medical staff and the nursing staff. Um, we did software and protocol education, and there was a huge focus on our new workflow and logistics. How do you keep track of your patients? How are you ordering levels? What information needs to be included in handoff from one person to the other so that we're optimizing a workflow and efficacy? And then we created sample patient cases to make sure that our pharmacists could be able to reproduce some of the key principles of our protocol. For nurses, or for physicians, we had to decide whether we were going to give access to physicians or not, the ID physicians versus everyone else, and this is something that they were very engaged in. We didn't worry about the small details of the protocol. They really just needed to know that we were targeting AUCs now and what the clinical benefit was to their patient, and we really focused on quality, safety, and interpretation of levels in terms of their education. And then finally, for the nurses, this was a really big education effort as well. We did hospital-wide and system-wide education. We wanted to make sure that they had general talking points for rationale for AUC dosing, how to transition from trough-based dosing to AUC dosing, when it was still appropriate to draw timed levels and what those would look like, and then interpretation of levels. So we weren't, and so that some of these questions were coming to us because we were managing 100% of our patients instead of the physicians now. So this is what our volume looked like over time. The entire system did not go up at once. And so if you are at a big system and you think that, every single one of your campuses need to go up at one time, I think we're proof that you can do this in a staggered fashion. And it ended up actually being working out really well because campuses who went live early were able to share their experiences with campuses who went live late, and we were able to build. You can see that as our volume went up, our users went up, and 80% of these patients that we're dosing are using the one compartment standard vancomycin model, with maybe another 15% with a 2-compartment model for our unstable renal function patients, and then maybe another 5% with our hemodialysis patients. And then it was really nice to be able to celebrate some of our successes. And so you can see that almost 90% of our patients with the one compartment model. And so what this means to us is a loading dose, maintenance dose as dictated by DoseMe, and then one level. We were able to have therapeutic AUCs at 48 hours of 90%. And so this was really huge because our traditional vancomycin trough-based dosing protocol prior to this at 72 hours, we were only able to achieve this 50 to 60% of the time. And so this was really great, and I think it says something to the intuitiveness of Bayesian dosing and everything that it takes into account. Finally, I wanted to show you guys our trough versus AUC plot for our system year to date. Um, the blue box shows you a trough of 10 to 20 and the percentage of doses that fell within that trough range. The yellow box shows you an AUC target of 400 to 600 and how many doses fell within that. And I don't know if you'll notice, but I actually have this yellow box stretched back to 350 because when you're targeting an AUC of 400, you've got a little bit of leeway. And so for skin and soft tissue infections and for patients who were clinically improving, we didn't necessarily push the dose just because they were at the lower end of our AUC range. And you can see this, and as Dustin will talk about as well, this really translated to an impact in terms of AKI and lower doses used. So I'd like to wrap up with some of our do's and don'ts that we learned. First, I think that we keep continuous lines of communication open with IT even after the launch. There were a lot of things that they were really helpful with or things that we still had to navigate, and that relationship was really important. Be ready to answer questions for staff, and then have the clinical specialist shadow the other pharmacist to confirm dose selections. For the first probably month that we went live with DoseMe, my personal approach was to kind of camp out next to the pharmacists who were doing vancomycin, and I would hang out there for an hour or two in the mornings and an hour or two in the afternoons, just because if you're sitting there, they're really more willing and ready to ask questions about what about this, or what do you think about that? And that either allowed me to address education deficits that they may not have picked up on when we did our didactic or our live education sessions, or, you know what, this is really unclear and we need to go back and adjust our protocol and our directions to the staff in terms of how to manage these types of situations. There is going to be a learning curve. And one of the things that was really helpful to us is we kept a living frequently asked questions document. So any question, whether it was an education-based question or something that needed to be adjusted in the protocol, we added to this FAQ document. And so when we were off-site, the pharmacists were able to scroll through these questions and kind of up their understanding and be able to handle questions based on the FAQ document. Lastly, follow discontinued bank orders for appropriate discontinuations, and then therapy not warranted or concerns over AM lab levels, and being able to help the medical staff manage those. Now, in terms of our don'ts, we had to remember that the written protocol will, don't think that it's not going to be defined. I feel like that's a living document as well, and still is. Like a year later, we're still making adjustments and tweaks, and I think that's absolutely okay because we're constantly learning from our experience. Don't assume that the staff will do everything that exactly as you intended. We've already seen variation in practices. I think some of them are appropriate and some of them we've had to re-educate staff on, and those have been important lessons learned for us as well. And then don't forget to prepare for EMR downtime situations. And so this is one of the, I guess, caveats that we did not think about since we're a fully integrated DoseMe site. When the EMR goes down, DoseMe goes down as well. So we had to prepare our staff for how to handle those situations, and then come up with initial dosing recommendations until the EMR was back up and we could run models in DoseMe and then adjust doses after that. So thank you for letting me share our experience. I hope some of this was helpful to you. And I would like to hand it over to Dustin to talk about the clinical, financial, and operational benefits of Bayesian dosing.